Hello, everyone. Thank you for joining us. Hi, everyone. Thank you for joining us at ISCP 2021. I hope everyone has enjoyed today's session so far. My name is Ruth from the Woodlands Health Campus here in Singapore. So lately, the SGLT2 inhibitors and GLP-1 agonists have been hogging the cardiovascular limelight. But for today's session, we will be revisiting our old friend, the sulphonylureas, in today's pro-con debate. Is aptly titled, "Don't Throw Out the Baby with the Bathwater. Should we or should we not still use sulphonylureas for patients with cardiovascular disease?" Today, we have with us two very special speakers. Dr. Celine Aquino will be presenting the side of the pro that we should still use sulphonylureas for patients with cardiovascular disease. Dr. Aquino is a consultant at the Chung Hua Hospital in Philippines. She completed her internal medicine residency and went on to complete a fellowship in adult cardiology and research fellowship in peripheral vascular disease and biology at St. Luke's Heart Institute. She is a celebrated researcher and teacher in the field of internal medicine and cardiovascular diseases. And presenting the flip side of this debate, we have Professor Mark Cooper. Professor Cooper is the head of the Department of Diabetes at Central Clinical School at Monash University in Australia, as well as a senior endocrinologist at the Alfred. He is also an eminent researcher in the field of diabetes with nearly 600 publications, and his work has improved our understanding of diabetes and its many complications. And with me today is my co-moderator and panelist, Professor Jack Tan, Deputy Head and Senior Consultant at the National Heart Centre Singapore and President of the Asian Pacific Society of Cardiology and President of the ISCP. So just to run through some house slides before we begin, the content of this webinar is copyrighted. All views presented are the speaker's own. CME points will be awarded and a certificate of attendance will be given to all participants. So do feel free to chime in at any time with your questions on the sidebar, and we will address it at the end of the session. So without further ado, I would like to welcome my first speaker, Dr. Celine Aquino, to begin our debate that we should still use sulphonylureas for patients with cardiovascular disease. Dr. Aquino, please.
With all the guidelines and the guidance, the consensus statements on achieving glycemic control in cardiovascular disease patients with type 2 DM, it is not surprising then
that clinicians are tempted to give in to a sweeping response of throwing the baby out to the bathwater
with all the guidelines,
hypoglycemic agents. I am here to speak on why we should not turn our backs on the sulphonylureas for patients with type 2 DM and cardiovascular disease. I am on the Speaker's Bureau of these pharmaceutical agencies. Otherwise, I have no commercial interests or research grants from any pharmaceuticals. It cannot be denied that there has been a sea change in the diabetes algorithms, and this is primarily because the accumulated evidence from recent large studies have demonstrated for the first time that anti-diabetic agents can produce positive effects on cardiovascular outcomes, including cardiovascular mortality. Today, there is a concentrated effort to make the SGLT2 inhibitor and the GLP-1 receptor agonist frontline choices, relegating even metformin to the background. And there is particular disdain among many for that granddaddy of all oral hypoglycemics, the sulphonylureas. This is perfectly understandable when we consider that cardiovascular disease is the primary mode of exit for most diabetics. And today, many authorities put the ability to reduce cardiovascular disease risk as the most important feature for a hypoglycemic agent. But while it is true that cardiovascular risk reduction is the parameter that should trump any other for choosing an agent for type 2 DM, it is also true that suboptimal A1C is associated with higher risk for micro and macrovascular events. And if the A1C remains elevated to more than 7% during the first year of treatment, the risk for mortality is higher. So therefore, an agent that effectively lowers A1C retains its relevance. So in addition to control of other risk factors, achieving the optimal levels of glucose remains an important part of type 2 DM management. Still, the situation was such that there was actually an editorial in 2013 that asked the question, has the sun set on the sulphonylureas? And one of the reasons for the bias against sulphonylureas was the disappointing outcomes in the studies promoting aggressive glucose control. These usually involved sulphonylureas, and they included the ACCORD that showed a definite mortality risk and the UKPDS and VADT showing a trend. But the ADVANCE was a very large study too. And unlike the others, the trend was towards favorable outcome. Now, why was this so? Analysis of the data would suggest that the difference lay in the duration of type 2 DM and the patient selection. That the patients in ADVANCE were generally without target organ damage and had type 2 DM of relatively shorter duration. It was this insight that laid the foundations of what we now accept as the legacy effect. Data from the long-term follow-up of the UK PDS population concurred. When strict glycemic control and intensive therapy are started early in the course of diabetes, it will result in less target organ damage decades later. As a result, the current guidance is that higher A1C targets are recommended for patients with established cardiovascular disease at high risk for developing the same and for long-standing type 2 DM. And for type 2 DM of shorter duration, and especially those without target organ damage, lower A1C targets are indicated. The updated algorithms look pretty complicated, but in essence, it organizes the recommendations in separate algorithms for patients with and those without established ASCVD or who are at high risk thereof. When there is high risk for evidence of established ASCVD, heart failure, or CKD, the preferred agents are GLP-1 receptor agonists and SGLT2 inhibitor. But then we see that in the guidelines, if despite this, the target levels of A1C are not achieved, there is recommendation for second-line drugs, and the sulphonylureas continue to appear in the recommendations. In fact, we see that even with all the new evidence, the current guidelines do not totally discount the use of sulphonylureas. So should we continue to use them in patients without CVD? To begin with, the rise of new formulations does not mean that we should immediately disregard the old drugs. After all, the adage goes, new friends are silver, but old friends are gold, and sulphonylureas are old friends. The concept, the egregious 11, focused the clinician on a beta cell-centric approach. That is to preserve the beta cell at almost all costs. And this suggests that a drug like the sulphonylurea that works by stimulating the beta cell would be inimical in the extreme. So we need to scrutinize the arguments against using sulphonylureas in patients with CVD. And I've narrowed this down to 4 issues. That sulphonylureas increase cardiovascular mortality and morbidity, that they have a greater risk to cause, greater potential to cause hypoglycemic events, they promote obesity, and cause beta cell exhaustion. Now let us take each one in turn. The first issue is, do the sulphonylureas cause excess cardiovascular death? For years, this was believed to be so, a belief that began with a study done by the University Group Diabetes Program in the 1960s, with a first-generation sulphonylurea that has since been withdrawn from the market for its adverse effects on the cardiovascular system. This 1960s issue was not revisited until much later, by which time the prejudice was firmly entrenched. But is there a basis for this prejudice? Is there a pathophysiologic reason for the charge of increased cardiovascular mortality? Sulphonylurea receptors, or SUR, are present in many tissue. Apart from the SUR1 in the pancreatic beta cells, there are SUR2 in the cardiac myocytes. Interfering with the SUR of the heart can work havoc on the potassium ATP channels and compromise protective ischemic preconditioning, as well as promote arrhythmias. The ability to block SUR in the pancreas is more or less the same in all sulphonylureas. But in the case of the SUR in the heart, glycoside, when compared with others like agents, shows a declining ability that also happens to be reversible. This makes the relative affinity to bind SUR2 an important aspect of the sulphonylurea safety. But in the end, the proof of the safety of sulphonylureas came from an unexpected source. The Carolina was the CVOT for the DPP4 inhibitor linagliptin, but it ended up proving the cardiovascular safety of the sulphonylurea glimepiride. The investigators say they do not know if this can be generalized to other sulphonylureas, but they admit it's very likely, especially as other sulphonylureas like glycoside have been shown to have even less affinity for the myocardial SUR2 receptor than does glimepiride. In addition to this assurance of safety, we also recall that the favorable outcomes in the ADVANCE was driven by a reduction in adverse renal endpoints in diabetics by as much as 46%. And safety in CKD is a feature of glycoside, glimepiride, and glipizide. The second issue is the risk of hypoglycemia, because hypoglycemia represents an additional risk for adverse outcomes for CVD. Well, the risk is inherent in all drugs that control hyperglycemia. But in 2020, Zaccardi and Associates reviewed cases enrolled in the United Kingdom's Clinical Practice Research Data Link to investigate similar comparison between a sulphonylurea glycoside in a modified release form and the DPP4 inhibitor sitagliptin. we see that now where there were numerically more hypoglycemic events with glycoside, overall the numbers were still very low. And there was a comment that the CPRD database did not discriminate between degrees of hypoglycemia and lumped minor cases with severe forms. So that overall the conclusion was that glycoside MR was not associated with significant risk for clinical hypoglycemia. The UK CPRD data link referenced several studies and concluded that the sulphonylurea glycoside does not significantly increase the risk for hypoglycemia more than would a DPP-4 inhibitor. Other studies also make the same observation, and we recall that DPP-4 inhibitors are particularly known to have a favorable profile for hypoglycemic risk. Some of these studies were also very cogent as they were made during the fasting month of Ramadan among Muslims. And hypoglycemia is further prevented in that situation by using a modified release form of the sulphonylurea, as well as shifting the timing of the modified release form of the glycoside from morning to the evening. In 2020, the KDIGO guidelines for management of type 2 DM in patients with CKD did not specifically say that sulphonylureas are contraindicated in CKD. Caution is recommended for agents that stimulate insulin production, but they add that the risk for hypoglycemia can be modified by using devices for continuous glucose monitoring and assiduous self-monitored blood glucose. In the updated guidelines, the algorithm for the diabetic who is prone to hypoglycemia, and this includes not only the fragile, but also those who live alone or those who are at increased risk for falls. And then they call for the drugs with the least potential for hypoglycemia to be given alone or in combination to achieve target A1C. Failing to achieve the target A1C means that we dig around the other classes and we again see the mention of sulphonylureas among the drugs utilized to achieve targets. Do sulphonylureas promote obesity? Obesity is a recognized risk factor. It's not only the obesity per se, but the unwise lifestyle choices that led to the obesity that make it such an important risk factor. So it is important to settle the issue. Do the sulphonylureas cause weight gain? As an anabolic hormone, insulin is associated with weight gain, and drugs like the sulphonylureas that promote insulin production would in theory cause the same side effect. But this was not seen in the VIRTUE study, where sulphonylurea treated patients actually had a decrease in weight in addition to observed reductions in fasting sugar and body weight. Patients treated with metformin and glycoside in the STEADFAST study had an adjusted mean reduction A1C by 0.03% and in body weight by 1.1 kilogram. So no, weight gain does not appear to be a major issue, at least with some sulphonylureas. The new algorithms therefore recommend for the diabetic with weight issue those drugs with the lowest potential for weight gain as first line and second line. But again, the sulphonylureas remain in the mix for the purpose of achieving optimum glycemic control. The fourth issue is beta cell exhaustion. The negative effects of beta cell exhaustion include worsening of the metabolic syndrome and increased risk for premature cardiovascular death. In theory, and sulfonylurea by squeezing the beta cell dry is harmful because it leaves the pancreatic beta cell exhausted. Are sulfonylureas really this evil and cause beta cell exhaustion? Lest we forget, sulfonylureas have positive effects with glucose metabolism too. In ADVANCE, there was no evidence of beta cell exhaustion as manifest by an increase in insulin use. But in the ADOPT, which is a diabetes outcome progression trial, glibenclamide was associated with earlier treatment failure than metformin and rosiglitazone. So perhaps the second reason for the outcome difference between the ADVANCE and all the other big trials is not just population selection. Perhaps it was also the choice of hypoglycemic agent. The evolution of patient-centric management cycle requires to make plans that are smart, that are also shared. That is to consider all aspects of care, including the patient's preference and ability to maintain his drug regimen. So that if cost is an issue, a major problem for many people, especially in our part of the world, the sulfonylurea and TZD now become first line. They're the cheapest in the armamentarium, and they too can be combined if targets are not met. Basal insulin, DPP-4 inhibitor, and SGLT2 inhibitors are now second line in this sub-indication. And this algorithm puts emphasis in using the sulfonylurea with proven cardiovascular benefit. In support of this, we recall an established dictum that rational pharmacology requires that medicine should be appropriate to the patient's clinical needs in the correct dose and duration for the indication and at the lowest cost. In acknowledgement of the continuing relevance of sulfonylureas, the sulfonylurea is the add-on oral hypoglycemic agent of choice after metformin in the STENO-2, a multi-risk factor intervention trial that proved that the holistic approach to cardiovascular disease management results in enhanced quality of life and improved survival. In summary, the updated guidelines for managing type 2 DM specify SGLT2 inhibitor and GLP-1 receptor agonists as first-line agents in patients with existing heart failure and CKD, and those at high risk for CVD. Yet they acknowledge that there remains a niche for sulphonylureas even when type 2 DM is complicated by existing CVD. Are sulphonylureas harmful? Not necessarily, because not all sulphonylureas are created equal. And sulphonylureas like glycoside, glimepiride, and glipizide have characteristics that make them safer for the heart. Studies like the Carolina and the UK CPRD validate the safety of later generation sulphonylureas. Weight gain and hypoglycemia are not major issues when we use a modified release form of glycoside. Therefore, to the question of are sulphonylureas still relevant in patients with CVD, after considering all factors, overall CV car risk profile, CVOT results and safety, patient's preference and capability to afford, the answer should be and is absolutely. Thank you for your attention.
Thank you very much, Dr. Aquino. Thank you for this first part of the debate arguing for the use of sulphonylureas. And next, I would like to welcome Professor Cooper presenting his side of the debate that we should not be using sulphonylureas for patients with cardiovascular disease. Professor Cooper, please.
Professor Cooper, you need to be unmuted.
Thank you. It's a pleasure to answer the debate, and I would like to say, Dr. Aquino, I think you've given some very good evidence to support your case, but also plenty of evidence to support my case, using words like niche, and if there's no cardiovascular disease, certain issues rather than others. But overall, I think the data are very convincing, with the newer drugs in particular, that sulphonylureas are not an appropriate first or even second line drug for patients with type 2 diabetes and cardiovascular disease. So sulphonylureas were originally discovered by researchers who were actually looking at sulfonamide antibiotics and discovered that they killed animals and soldiers. So we already knew these were going to be drugs that might cause problems. And we heard already from the previous speaker that this whole story was really dramatically exposed in the UGDP program, where there was a dramatic increase in mortality in a group that received a sulphonylurea compared to insulin. And that already started the whole issue about sulphonylureas. And so there was a special warning of an increased risk of cardiovascular mortality, particularly when compared to diet or diet plus insulin. So we already knew that there was possibly a problem with sulphonylureas. And we knew not only that they were definitely not beneficial, but potentially deleterious. And the problem is with sulphonylureas that they only do one thing: they lower glucose. And in diabetes now, we have an opportunity to do more than lower glucose, but protect the organs that are affected by diabetes. And you can see here in the ACCORD study, which was a study where there were a lot of patients receiving sulphonylureas, you can see that there was indeed an increase in mortality overall. Particularly here you can see, and it was particularly seen in those people who'd had a previous cardiovascular event. So although the previous speaker did mention the possibility that you could use sulphonylureas, the one group where one would be very cautious and worried are those with a previous cardiovascular event. And we know from the VADT, again, we see no benefit when we use sulphonylureas. This was a trial that used lots of drugs, including insulin, but there was a significant number receiving sulphonylureas, and particularly in people with evidence of coronary artery calcification. You can see in the high score of over 400, you can see here that there is no benefit of this intensive glycemic control, which includes significant use of sulphonylureas. So from the early data in the 60s, where we saw an adverse effect, we saw again a similar either disadvantage or no benefit in those patients receiving these drugs in the studies done in the 90s and after 2000. So what we know is that if you have a history of macrovascular disease, no conventional glucose lowering, predominantly using trials which included sulphonylureas, the hazard ratio is 1. So you're delivering nothing using glucose lowering with the older agents. So we know that's why we can't use sulphonylureas. And indeed, when we used meta-analyses with the TZDs like rosiglitazone, we saw no benefit and potentially an adverse effect. And when we do the meta-analyses with the sulphonylureas, again, we see no benefit. And if you look here at a comparison of metformin, for example, and you compare that to a sulphonylurea, you always see an increase in the adjusted hazard ratio, up to 20% for death. And this means that there is a problem with this class of drugs. So we need to also know that a lot of these new trials, we're starting to use the newer agents. And because the newer agents have benefits, even if you give these people sulphonylureas, you may not see the neutral or adverse effect of this class of drugs because you have the benefit of the newer glucose lowering drugs. So if you look here and you look at the effect of SGLT2 inhibitors or GLP-1 receptor agonists, you see all the hazard ratios are less than 1. I've shown you with the sulphonylureas, the hazard ratio is either 1 or either greater than 1. So we now have drugs that are end organ protective. So why would we even consider an old class that's not particularly effective? So the other problem is that we haven't had any specific studies where we've said we're already using the end organ protective drugs, let's add a sulphonylurea. And because these drugs are already so good, no one is even considering doing formal studies in this situation. So one of the issues that you need to mention, and was vaguely alluded to, although under-exaggerated by the previous speaker, is the issue of hypoglycemia. And this is a very important issue because hypoglycemia is commonly associated with death. And indeed, if you ask a patient, what are you worried about? What are your greatest fears? Hypoglycemia is on the list as one of the major fears of type 2 diabetic patients. And so we don't want to give a drug that not only doesn't do anything of major benefit to 1 to 4, the end organ injury, but also causes hypoglycemia. Now, why is it that this hypoglycemia is such a worry? Well, it turns out that which of these factors are caused by hypoglycemia? Well, we know that hypoglycemia increases sympathetic activity, prolongs the QT interval, is associated with a modest increase in blood pressure, promotes coronary vasoconstriction, and indeed the answer to this question is that all of these are seen with hypoglycemia, and yet you're considering giving it to a person who already has cardiovascular disease. So again, hypoglycemia is not something we want to have in a diabetic patient, particularly now that we have so many drugs that are not associated with this side effect. And indeed, in this nice review in 2012 by Inzuki, probably as a result of the findings of the ACCORD study, you can see that hypoglycemia probably exacerbates myocardial ischemia and that these medications are likely to predispose to this adverse event. And so many parts of the world, these drugs are less and less preferred. What else does hypoglycemia do? Well, not only does it have all those side effects, but patients are nervous taking those drugs because they're worried they could have a hypoglycemia. They could be driving a car, involved in some work effort. And because they're not confident about this with respect to hypoglycemia, there is a reduction in adherence. So if we look here at the Carolina study, you can see here, when you compare the sulphonylurea to an alternative agent with very similar glucose-lowering efficacy, in this case linagliptin, there is essentially a 6 to 7-fold increase in hypoglycemia with glimepiride. And so even though this is a newer SU, one of the newer classes, we're still seeing significant hypoglycemia. And there was also an even further increase in requirement for hospitalization due to hypoglycemia, almost never seen with the DPP-4 inhibitor and seen with glimepiride. So we are lucky because we've just had a very recent study, the results of the GRADE study, which looked at people who are already on metformin and randomized them to 4 potential options as a second drug. And in many of the conventional guidelines till very recently, these were the options that were recommended, either a sulphonylurea, in this case glimepiride, a DPP-4 inhibitor, a GLP-1 analog, or insulin. And what was clear is that of all the agents, liraglutide was the best at reducing the end organ complications, building on that anti-atherosclerotic action that's been seen with the GLP-1 analogs in many of the trials and never seen with a sulphonylurea. And if you look here at any cardiovascular death, you can see that blue line showing not only is the SU not able to achieve what you see with liraglutide, and therefore what you're dealing with is a drug that is not the best. And we want these people not to develop cardiovascular disease because cardiovascular disease is the major cause of premature mortality in the diabetic population. And if we look, you can see here, when we look at liraglutide versus the other agents, it clearly is much better. And if we look at MACE, again, we're seeing the lowest level is seen with the GLP-1 agonist. And even further, we see, even in heart failure, which is not a feature that any of these drugs are associated with, we haven't got an SGLT2 inhibitor here, we see the advantage of the GLP-1 agonist, and we see glimepiride right at the top, compared very similar to what you see with insulin. And ultimately, mortality is the final line, and again, we're seeing the superiority of the GLP-1 agonist. So we've got type 2 diabetes, cardiovascular disease, and clearly sulphonylureas show no benefit when there are now drug classes that do. So this is very familiar because currently we have worldwide a COVID epidemic. We have 2 vaccines that are both very effective, but one appears to have less side effects than the other. It may even be more potent at some of the viruses, but the key difference is that you have 2 options. And that is why in most parts of the world, people would pick one vaccine over another. So even if the side effects are small, if your competitor has an extra benefit without the side effects, then how can you compete? And so in diabetes, I think we have a similar situation. We have a class of drugs that doesn't cause hypoglycemia, doesn't cause weight gain, which I didn't discuss, and then another drug which is quite effective, but it does have side effects. And that's in the context where there are options that are safer as well as conferring benefits on end organ injury. Thank you very much.
Thank you very much, Professor Cooper, for presenting your side of the arguments. And I will now hand the time back to Dr. Aquino to present her rebuttal towards Professor Cooper's side of his argument.
Dr. Aquino, I think you need to unmute yourself.
I'm sorry. So I agree that if the patient does have heart failure and the CKD, we are absolutely going to encourage our patients to take it. But the question here is, should we still consider sulphonylureas from the as a point of view, should we still consider sulphonylureas? And when we consider the importance of maintaining the other slides, if the importance of maintaining an adequate sugar control, I should say that it would be very much necessary for us to consider that in addition to the original drugs, we should, the SGLT2 inhibitor, we should also, other one. I'm sorry, I'm trying to access my slides. That one. I'm sorry. Okay, I'm sorry. Cool. So in addition to thinking about the evidence about survey about the evidence of patients being able to survive better with SGLT2 inhibitor, I understand that the process here is about autophagy, that these drugs are actually able to help the body to kind of recycle themselves. Okay.
So Dr. Celine, maybe you can just speak to it without your slides, if you may.
Sorry, yeah. I'm terribly sorry. I did prepare my slides for the rebuttal.
But it's all right. Maybe you can just speak to it rather than flashing it.
It's just, I'm sorry. I do agree with Professor Cooper's presentation that it is very important for us to consider that there is a survival advantage with the new drugs. And the sulphonylureas, unfortunately, do not have that same survival advantage. But when we're trying to decide to discount a previously accepted intervention, we should at the very least examine the supporting arguments that had been made in its favor. So what is undeniable now is that the SGLT2 inhibitor and the SGLP1 receptor agonists have strong supporting evidence for benefit in those patients with established CVD or those who are at high risk for CVD. So that in the patient with heart failure and CKD, both of these are diseases characterized by an excessive increase in intraluminal pressure. The SGLT2 inhibitor would be a great drug since that's what it does. We also consider that the evidence supports achievement of optimal glycemic control. It is an essential target for CVD management. And this is because although Professor Cooper said hypoglycemia is terribly bad for a patient's CVD, hyperglycemia is just as bad. It induces the mitochondrial superoxide production and it stresses the endoplastic reticulum. And this then results in inflammation that promotes endothelial dysfunction and initiates atherogenesis that then manifests as micro and macrovascular disease. And it also occurs to me that this separation of algorithms according to the presence or absence of heart failure is artificial, because we must bear in mind that type 2 diabetes mellitus is already considered as stage A for heart failure. And this means that type 2 diabetes mellitus is already a cardiovascular disease. And as they said in the previous presentation, that the adage said that old friends are more valuable than new ones, remember that the sulphonylureas are old friends, and moreover, they do work. It may not have the same evidence of prolonging life and improve mortality, at least to the data that we have right now, but they do work. Their impact on cardiovascular events is that they lower glucose levels too. And the safety issues have already been discussed, that it may not be a matter of sulphonylureas in general, but some sulphonylureas. Diligent study of the guidelines for glucose lowering in type 2 DM with high risk or established CVD, we see that the continuing presence of sulphonylureas says that there is a caveat in heart failure patients and excludes TZDs, but not the sulphonylureas. SGLT2 inhibitors promote autophagy, as I said. It renders the organism capable of recycling itself. These worn out organelles can create more efficient cells, a kind of a regeneration or refreshment of a tired cell. The sulphonylureas do not have such dramatic supporting data, and this is all true. But the better medicine in the end remains the one that the patient can sustain. because when multiple drugs are needed in a patient with established cardiovascular disease, the hypoglycemic agent is one among very many. And in the hierarchy of drugs, we're going to concentrate on antiplatelets and others over the hypoglycemic. And in order to maintain, the cost will become a major issue. So the right sulphonylurea will therefore continue to hold their own in the management algorithms for glucose lowering. And to the question of, has the sun set on the sulphonylureas? The thing is that on one side of the world, it may be a sunset, but on the other side of the world, it is certainly a sunrise. It's all a matter of perspective. And when we consider something new, we shouldn't turn our backs totally on those that are tried and true. Ball in your court.
Thank you very much for Dr. Aquino. And that was certainly a very hearty debate from Dr. Aquino. And I'll now hand the time over to Professor Cooper. Okay. Oh, well, yeah.
Thank you very much, Ruth. So I've seen some very interesting questions as well, but fit in very nicely with the theme of the debate. So clearly sulphonylureas are not the first line that you would use in patients with cardiovascular disease, but there is the issue about what you do in certain contexts and where they can be used. So one of the issues is that some patients can't tolerate metformin, and that occurs in up to 10%. And here SUs are an option to consider. And if you look at the GRADE study, you do see that the DPP-4 inhibitors, which have been the major comparator in the trials, don't really offer that much more over the SUs. Where the SUs are now losing the battle is because we have newer agents like SGLT2 inhibitors and GLP-1 receptor agonists. Historically, the fight was with the DPP-4 inhibitors, which are generally drugs that don't have significant side effects, but they have not delivered the end organ benefits we hoped, as has been clearly seen in all the cardiovascular outcome trials. So I think SUs still have a place, but they're pretty low down, and particularly in the patient with cardiovascular disease, which was the topic of the debate, they would be lower down than in a patient in an underdeveloped country where these drugs are very cheap, and I must admit, are pretty good at lowering glucose, and they lower glucose quickly, and that is often very useful. And even in the trials versus DPP-4 inhibitors, they tend to lower glucose quicker, but that's why one of the problems is hypoglycemia. And I think it's also very important to appreciate that the Carolina study included people who were not on insulin relatively early in the diagnosis of diabetes. So I think there's been an overinterpretation of Carolina in terms of cardiovascular disease because we were using a totally different population, and maybe the trial should have been done in the Carmelina, more advanced cardiovascular renal population, where I suspect the sulphonylureas would have been even less favorable. So I think we have to think about when we use them and definitely not use them in the high risk, more advanced patient. Thank you very much.
Thanks, Professor Cooper. I see another question from the audience. Maybe Prof. Cooper can answer that as well. You show a nice chart saying that the hazard ratio is exactly 1 for some SU use. Is that really, there are a lot of pictures to say some SUs are probably safer and better. For example, the more modern glycoside, the Bemperide. Yes. And there are some slow release formulation. Do you think all this actually makes a difference in terms of safety and which is better or not? Or is really a class?
So I think historically the issue was safety, but now we have benefit. Because we have newer drugs like SGLT2 inhibitors and GLP-1 agonists that offer benefit, then I think it's a new equation. If you're asking me, do sulphonylureas, are they neutral or deleterious? The old drugs were clearly deleterious. Probably the newer ones, particularly from a cardiovascular point of view, are probably neutral. I think that's best seen from the cardiovascular outcomes of the ADVANCE study, where most patients were on glycoside, and in that group, we didn't see an increase in hazard ratio. And what drove the benefit of the ADVANCE trial was the glucose lowering effect of the glycoside, because glucose lowering is definitely very good for microvascular complications, including the kidney. And as you might remember, the ADVANCE trial was a composite endpoint, cardiovascular and renal, but the cardiovascular endpoint was a hazard ratio of 1.
Anything else to add, Dr. Aquino, to that?
I would agree. However, if we're talking about issues like safety, I think it is inherent in a drug that it must not only be effective, must be safe. And the fact that the very large studies were made on patients who were particularly prone to hypoglycemia. I mean, those patients who were the Muslims in the Ramadan, and there were actually very little evidence of hypoglycemia during those in that patient population. So I would say that it makes a huge difference that there's a modified and an intermediate release form for the sulphonylurea. And as for using them as a first-line drug, I think there's no argument here that if the patient is in heart failure, an SGLT2 inhibitor would certainly be the drug of choice. But then if the SGLT2, which isn't really a very strong hypoglycemic agent, it fails to control the glucose, it is certainly acceptable to add a sulphonylurea to that regimen. And it has been added, and that makes it still very much in the mix. Maybe not at the front line, but certainly still in the picture.
Can I just ask two of my own personal questions at the two speakers, if you may, Ruth? One is, Prof. Cooper, again, you have now DM drugs finally with CV outcome benefits. So it's really a hard sell not to use them for my group of patients, right? But between SGLT2 and GLP-1 RA, frankly speaking, injectables are not easy to use. So what do you think? Is which one are you going to start first? Is that
a great question? And I think we actually have the data
GLP-1?
Because we have so many trials now, and we just had that recent trial with another GLP-1 agonist in the New England. I can't remember its name, it starts with the trial. But what is important to say is if you've got renal impairment or heart failure, SGLT2 inhibitors are the winners. The GLP-1 agonists have really no effect on heart failure. So they are definitely not the drug of choice. In renal, both work, but SGLT2 inhibitor is better. And I think in the longer term, the combination will be more and more used. In terms of atherosclerosis, the data is much better with the GLP-1 receptor agonists. And ultimately, we will have oral GLP-1 agonists for the people that don't like injectables. But I think a once-weekly injectable is tolerated. The bigger problem there are the GI side effects with this class of drugs. So I think injectable GLP-1 analogs are the most impressive for atherosclerosis, and in particular for stroke. If you want to prevent stroke, there are no data that SGLT2 inhibitors are helpful at all. There is even a potential signal against them, although probably that's not real, whereas the GLP-1 agonists probably do reduce stroke.
Well, personally, thanks, Prof. Cooper. Yeah, I think there are a couple of questions that we have from the audience that pertain to patients with renal impairments. And as a cardiologist myself, I always see patients with fluctuating renal functions and patients, even though they have a lot of atherosclerotic cardiovascular disease, their renal function can vary between the 30 to 40 EGFR mark. And therefore, personally for myself, I would still put them on a small amount of sulphonylureas while I titrate their SGLT2 inhibitors and perhaps even still use metformin. So I'm just wondering, in real life practice, how would you use all these oral hypoglycemic agents with in patients with chronic renal impairment, and a lot of our patients also might even be on dialysis?
Yeah. So in terms of renal impairment, I think it's quite clear now that because you've got two issues here. With renal impairment, the problem is that the SGLT2 inhibitors are not very good glucose-lowering agents. But we've seen from DAPA-CKD and Credence, and we'll probably see it soon with the EMPA-Kidney trial, they clearly confer this remarkable renal protection. So those drugs are going to be used for their renal benefit, not for glucose lowering. So then the question is, what do you do in someone with a low GFR and you want to lower glucose? So we are a bit limited. So metformin, we've reduced the level of GFR. We can give lower dose of metformin down to probably 30. SUs have increased hypoglycemia in patients with renal impairment, and particularly in older patients who often have renal impairment. And there you've got to cut the dose, and ultimately, even though the newer ones are better, they can't be used at very low GFR. So you are left then with the GLP-1 analogues. Some of them do have low GFR data and you can use them, but not in dialysis in general. And then you can use the DPP-4 inhibitors. And these are very good in patients with low GFR, but there is one particularly, linagliptin, which has the advantage, it's not a all or none advantage, that you can use the dose, the same dose, right through to dialysis. Whereas with the other agents, most of them, you can use them, but you have to remember to reduce the dose as renal impairment continues. So I think the historical situation where we mostly used insulin in these people, we can now often not use insulin. We've got lower thresholds for using metformin and sulphonylureas, and we have DPP-4 inhibitors. But the SGLT2 inhibitors are excellent in this group, but not for their glucose lowering effect.
Thank you, Professor Cooper. So while we're talking about the different classifications of patients, I'm also wondering, and also this is one of our questions from Andy. He mentioned about the geriatric populations, and to Dr. Aquino, so how would you use sulphonylureas or the other oral hypoglycemic agents in the geriatric population of patients who have multiple comorbidities, but the medications all need to be titrated quite carefully?
As cardiologists, we know that these are the patients where we spend a great deal of time with. We've got to make sure that they understand all the possible side effects as well as the need for constant monitoring. So when I have a patient who is much older, and right now they classify them into old elderly and young elderly. So I guess if the patient has some degree of incapacitation in addition, like a post-stroke patient, consider them old elderly, then I would be very careful about using the sulphonylureas, and I would prefer to use the modified release forms. And I would be also spend a great deal of time with the patient on the need for the patient to monitor sugar, the self-glucose self-monitoring, and as well as to be very, very aware of the signs of hypoglycemia. And the A1C is very useful also for monitoring whether the patient can be de-escalated in its management. I live in a really hot country, and the use of the SGLT2 inhibitor is, we advocate that kind of drug, but the problem you see in this very hot country is that you also have a very great tendency to cause a postural hypotension when they dehydrate. And there's also the risk for the genitourinary infections. And so, although I understand that in the patients with heart failure and CKD, these are the first-line drugs, I also make it a point to explain to the patient that I want their quality of life to be right up there. I mean, in the elderly population, it's not just our endpoints that we look at, we also look at quality of life. I mean, somebody with bladder issues already, or somebody with a prostate problem, it may not be the best possible drug to have something that causes some degree of diuresis. So I discussed that with them. I would use an SGLT2 inhibitor in an elderly person, and especially in the one with concomitant cardiovascular disease. But I do not rule out the sulphonylureas. And I usually would use a modified release form in the patient who is older.
Prof. Cooper, maybe you can
Well,
clarify.
I think in the older population, obviously it's a cost issue, but I have been very comfortable, particularly with the DPP-4 inhibitors. Obviously there are expense issues, it's a different cost, particularly in some parts of the world, but clearly in an older person, it is very good to use a drug that has basically a dramatically impressive side effect profile. Because in the older patients, it depends what we're trying to do, but in most of them, we want to do no harm and yet control their glucose. Obviously, they've got other end organ injury. Then you've got to start seriously thinking, would I consider some of the newer agents? And in some I do, but I don't find SGLT2 inhibitors in the older, frail population so easy to use.
can I also ask Prof. Cooper, we always hear that when they're elderly, the HbA1c threshold becomes a bit more flexible. Can you give the audience what is this flexibility up
so
to?
historically, the guidelines have gone to 6.5%, but most people, except if the patients are very young, tend to go for 7. And then for the older population, they say 7.5. But to be honest, you've got to be sensible clinically. So if a 92-year-old patient who's symptomatic because of hypoglycemia, and you can get their A1C down to 8% and they don't have any symptoms, I think you would accept that, particularly if you're avoiding hypoglycemia, which is something you really do want to avoid in the elderly, because if they fall over and break their hip, you're completely changing their outlook, their prognosis, risk of mortality, and in particular, the quality of life, which must be the focus of any management of the older population.
Thank you, Prof. Cooper. So I think there's one more question in our panel that's posed to the panel. That is comparing the different sulphonylureas. And I'd like to ask my two speakers here. I mean, certainly as we have talked about, there may still be a role for our old friends, the sulphonylureas, but and of course, Dr. Aquino has mentioned about the choice of using the ones with slower release. But in terms of all the different sulphonylureas, are there any differences in their cardiac profile, their cardiac safety, and personally, how would you choose it? Maybe I just pose this to Dr. Aquino first.
Well, I don't know if that would be the sole reason to choose it, but in the paper on affinity for SUR2 receptors to SUR1, glycoside has the highest affinity for SUR1 over SUR2. I think it's about 1:16,000. So that would theoretically make it a safer drug, although glimepiride will also have quite a safe profile, and glipizide as well. So its affinity for the cardiovascular SUR would make it less likely to cause problems in the heart, like arrhythmias or interfering with ischemic preconditioning. So in the choice of sulfonylurea, I just have to say that when it is an older person, I would really prefer to use a modified release form rather than just go right ahead and give them a sulfonylurea. The risk for hypoglycemia in the elderly, especially if they're living alone, is really too high. But still, when we look at the guidelines, they still consider that in the patients who are fragile and who are at high risk for hypoglycemia, the first choice, of course, would be the DPP-4 inhibitors, and the sulfonylureas would be quite low in the line for using the drugs for hypoglycemic control. But I would also like to say that in the guidelines, in the updated guidelines, the sulfonylureas continue to be a third choice. It is still there, even in the patients who are at risk for hypoglycemia, in those who are fragile and those who are at risk for fall. So this is evidence-based medicine. I would say that it must certainly be quite safe to use them in that indication.
So I would say the problem with the sulfonylurea issue is that a lot of it's theoretical or based on meta-analysis, and we will never have the trial where we compare glycoside MR to glimepiride. It's just not going to happen. No one's ever going to do the trial. So you've just got to look at the data yourself. I think one of the complicated situations has been that there's been very little glycoside use in the US. And so therefore the data of the guidelines internationally hasn't really addressed the issue of sulfonylureas. And although I've been debating sulfonylureas is not to be used in cardiovascular disease, the truth is that because the US did not have glycoside, they have a much more negative view of sulfonylureas than other parts of the world, where definitely the modified release of glycoside has turned out not to show any deleterious effects. And I think the advanced study, which include 1/3 of the patients were actually Asians, you can see that these drugs can be used in this population. And I think we shouldn't throw them out, but I do think they're not first or second or even third line, probably in the cardiovascular population. But there are many patients on multiple oral agents who don't want to go on insulin, and you add a sulfonylurea and you can control their glucose, and avoid secondary failure. So there's no question there is a clinical role for these drugs. It's just where they are in the hierarchy, I think, is that they're dropping as time goes on, as the other drugs have more data and themselves become cheaper.
Can I just ask Prof. Cooper also, in all your studies, TZD seems to have dropped off the radar for cardiovascular use. Maybe you can make some comments about when you're considered and when is it contraindicated?
So I think it's a great question. So they're still in the guidelines and they are pretty impressive drugs. The problem with the TZDs is at least twofold. The first is that the response to TZDs is unbelievably variable. And some people just do not respond to them at all, where some people respond spectacularly to them, often in association with dramatic weight gain. So there is a problem that these drugs have side effects, but in some people are very impressive. And what we've discovered is that the dose response curve is pretty flat, and yet the side effects go up with the increased doses. So I've increasingly used in certain populations, particularly women, I found, low-dose TZDs stop people requiring insulin. And so I don't think we should throw them out, but we are talking again about third, fourth, fifth line drugs. And definitely in the context of heart failure, they're clearly not ideal drugs.
Ruth, you have any other questions you want to direct at the speakers in the question list?
Yeah. Well, I think since we have about 2 to 3 minutes left, very quickly, I think we can also talk about the rest of the diabetic medications we have in our drug library. So I think one of our questions from Subramaniam is about using insulin in patients going into heart failure, because it's so difficult to use all these other oral agents. In practice, to our two speakers, how would you start off as a first line treatment in that case? Would you be using insulin first to control the glycemia, the sugars?
That's an excellent question. We have these very poorly controlled patients. They present with A1Cs of 10%, and historically we've commenced them on insulin. We're very fortunate now with some of the newer agents. I've just had one of our staff was in that situation and didn't want to go on insulin, and I was able to put them on a fixed combination of an SGLT2 inhibitor and a DPP4 inhibitor, as well as metformin. So you've got 3 drugs, none of them cause hypoglycemia, and you will see a very dramatic response. Most of them will drop 2 to 3% with that combination. And then you can decide, and that means you can avoid early insulin therapy. This is something 5 or 10 years ago, when we only had the older drugs, just insulin, metformin and sulphonylureas, where with an A1C over 10% in a symptomatic patient, you probably couldn't do it. But if they don't have ketones, I tend to try aggressive oral agents very quickly. The other important thing to appreciate is the GLP-1 agonists are very potent. They're almost as potent as insulin, and there's something to consider in these patients. So I think the old story that a patient with very poor control needs insulin, I think often we can avoid it now. I think in a younger patient where we're not sure if they've really got type 1 or type 2 diabetes, and we're waiting for some results like antibodies and wonder if they're LADA, I often give them insulin initially till I sort them out. But in general, if it's not that sort of a patient, a very obese, insulin-resistant person, I try oral drugs or an injectable rather than early insulin.
Thank you, Prof. Cooper. And Dr. Aquino, do you have anything to add for the use of insulin or any first-line therapies?
Well, I'm afraid that as a clinician, if the patient is critically ill, now at the time of COVID, when they're severely ill, or if a patient who is unstable in the ICU, I really would not like to trust any oral drug. I would like to go right ahead to insulin and titrate accordingly until the patient gets better. So I have no confidence in using oral drugs when the patient is critically ill or unstable, and I would prefer to use insulin during that time. Otherwise, I agree with Professor Cooper.
So
Okay, I would like.
Ruth, you would like to sum up before I close?
All right, sure. Yes. Yeah. Yeah. So thank you for Professor Cooper and Dr. Aquino for this very hearty and informative debate. And I think that the bottom line is a lot of our choice in the use of all these agents, boils down to our patient profile and having an individualized approach. And I think, as our speakers mentioned, it's also the boiling down to the choice of the agent itself. Certainly sulphonylureas has sort of fallen down in the ladder of use, but there seems to still be, a place for sulphonylureas in our choice of diabetic agents, and also to choose between the short and long actings also boils down to our patient profile. And I really want to thank my two speakers here today, for joining us in this very informative session.
Thanks, Ruth. And my last word is that, again, I really enjoyed the two debates. I think both of them express strong points, and I think the truth is somewhere in the middle. I just like to make a pitch to the cardiologists out there. I think as cardiologists, more and more, we do have to address the issue of the appropriate diabetic treatment in our CV patients for better cardiovascular outcomes. I think there are drugs nowadays with these benefits, but we do need to use the whole armamentarium of DM drugs to treat them well. So with that, I would like to thank everyone for their time for this session that I enjoyed immensely. Thank you very much, and keep safe during these pandemic times. Bye-bye.
Thank you. Good afternoon.
Thank you.